Welcome to the Multiple Sclerosis Virtual Grand Round Series, hosted by the Continuing Medical Education Department of the Cleveland Clinic. I'm Rae-Grant, staff neurologist at the Mellen Center for Multiple Sclerosis. I'll be moderating these virtual grand rounds on multiple sclerosis and related disorders. We hope you find these topics in MS timely, enlightening, and ultimately of use in helping you care for your patients with MS and related disorders. Our speaker today is Dr. Devon Conway, Associate Staff, Multiple Sclerosis Center for MS. Dr. Conway received his undergraduate degree from Cornell University in biochemistry, then his medical degree from Case Western Reserve University. He did his residency in neurology at Case Western, then completed a fellowship in neuroimmunology at the Mellen Center, and completed the Clinical Research Scholars Program at Case Western Reserve University. He has been instrumental in developing a care path for initial treatment for MS with disease-modifying therapy. Today, Dr. Conway will discuss initial management of MS with disease-modifying therapy. He'll talk about who should have treatment and who might not need therapy. He will discuss how to decide among the 10 FDA-approved medicines. He will highlight monitoring strategies for these medicines, as well as remind us about risk stratification for all the medicines. It is getting more and more complex to begin patients with MS on disease-modifying therapy. Dr. Conway will help smooth the way in our treatment decisions. Dr. Conway.
Thank you for the introduction. I am Devon Conway. I'm a staff neurologist at the Mellen Center for Multiple Sclerosis at Cleveland Clinic. And today we'll be talking about considerations in the initial treatment strategy for multiple sclerosis. So the first slide is just a review of the learning objectives for this talk, with the number one learning objective being to review the available first-line treatment options for MS. The second objective is to discuss the appropriate treatment choices based on the clinical presentation of the patient. And the final learning objective is to discuss monitoring strategies once a patient is on treatment. Just by way of introduction about multiple sclerosis, I just wanted to mention that it affects more than 2.3 million people worldwide, and that includes more than 300,000 patients in the United States. MS is an immune-mediated disease of the central nervous system, which means that it affects the optic nerves, brain, and spinal cord. And it consists of two components, both an inflammatory and a neurodegenerative component, with the inflammatory component typically being more prominent earlier in the disease, and the neurodegenerative component becoming more prominent later in the disease. And the exact cause of MS remains unknown at this point, but it does appear to develop in genetically susceptible individuals after exposure to some environmental factor. And again, exactly what that environmental factor is not known, but there are a number of risk factors that have been identified, including low vitamin D levels, exposure to tobacco, and late-onset EBV infections. This next slide is just an introduction to the FDA-approved medications for treatment of relapsing MS. The first treatment listed is interferon beta, which includes beta-seron and Extavia, which are the same medication, Avonex, and Rebif. And we'll also go through some of the major side effects or caveats with these medications. So for the interferons, the major side effects are these flu-like symptoms. So patients will sometimes get myalgias or headache, sometimes a little bit of fever with the injections, and hepatic toxicity is another issue. So their liver enzymes need to be followed. Occasionally these patients do get a little bit of a leukopenia as well, and sometimes they can also develop neutralizing antibodies, so those need to be assayed for. Our next treatment option is glutaramer acetate, brand name Copaxone, which is nice in that it does not have those flu-like side effects that you get with the interferons, but patients can experience site reactions at the site of the injection. So that can often be some swelling, some redness, sometimes some bumps under the skin. With long-term use, some patients will develop lipoatrophy, which is a dimpling of the skin. And some patients on Copaxone get what's called an immediate post-injection reaction, or IPIR, which is a self-limited episode that typically lasts about 5 to 10 minutes and consists of some heart palpitation, sometimes some tightness in the chest or shortness of breath. In most of the time, this is fairly unusual, but some patients will start to get it recurrently, and typically they end up needing to be switched to a different medication. Our next treatment option is mitoxantrone or novantrone, which has largely fallen out of favor among MS experts because of its potential to cause both cardiomyopathy and leukemia. Both of those side effects can develop months or sometimes years after the last dose of mitoxantrone is administered. So it's very rarely used these days to treat relapsing MS. Natalizumab, brand name Tysabri, is probably our most effective medication for treating MS. But the main issue with Tysabri, of course, is the risk of progressive multifocal leukoencephalopathy, or PML, which is increased among patients who are on natalizumab. Fingolimod, brand name Gilenya, was the first oral medication to be approved for multiple sclerosis. And it is usually pretty well tolerated, but there are a number of issues that go along with it. Gilenya can affect the cardiac conduction system by causing an atrioventricular block. So patients need to have an EKG before they start taking fingolimod. They have to be observed for 6 hours after they take their first dose, and then they have to have another EKG after that. Macular edema is fairly rare with fingolimod use, but because of that possibility, the patients need to have ocular coherence tomography before starting fingolimod to screen for any signs of macular edema, and we then typically will do it again 3 months after they start the medication to make sure that no macular edema has developed. It is somewhat more common among diabetics on fingolimod, so if you do start a diabetic on fingolimod, it's often customary to repeat the OCT more frequently, perhaps once a year or so. And you also have to worry a little bit more about herpes virus infections in patients who are being treated with fingolimod. 2 patients in the trials died from herpes virus infections, one from disseminated varicella zoster and one from a herpes simplex infection. So we always make sure that patients have either been exposed to chickenpox or vaccinated against it before they take their first dose. There has been one case of PML reported in a patient who was on fingolimod that had never received Tysabri before. The next oral agent to be approved was teriflunomide, or Aubagio, which does have the potential to cause hepatic toxicity. Because of this risk of hepatic toxicity, patients on Aubagio need to have hepatic function panels once monthly for the first 6 months. Other issues with teriflunomide include that it can cause GI side effects and that it can cause hair loss, which can be an issue for some patients. Finally, Tecfidera is our most recently approved medication for MS in the United States, which goes by the name of dimethyl fumarate. Its major side effects include skin flushing, so like a redness and a heat sensation in the skin, and also GI side effects such as abdominal pain, nausea, sometimes diarrhea. The incidence of these side effects typically decreases after about a month or 2 on therapy, and there are methods that can be used to help reduce those side effects. For instance, taking a baby aspirin once a day is often very effective in reducing flushing with dimethyl fumarate. Dimethyl fumarate can also cause a reduction in the white blood cells, There's also some concern about PML among patients receiving dimethyl fumarate, and this is because of some case reports that came out of Germany where a similar formulation of the medication is used to treat psoriasis. These case reports included 4 individuals who were on Fumaderm, as it's called in Germany, and developed PML. This was in the setting of very low white blood cell counts, so it is possible that that might be a risk factor for PML among patients treated with this medication. However, so far, no cases of PML have been reported among patients taking Tecfidera here in the United States. So we'll be going through a few cases, and the first case study is a 35-year-old woman who presents with an episode of horizontal double vision when she looks to the right. On physical examination, the only abnormality that's detected is a left internuclear ophthalmoplegia, and an MRI is performed, which shows a moderate burden of T2 hyperintensities that look typical for MS lesions. And also a enhancing lesion is detected in her brainstem as well as in the left frontal juxtacortical white matter. She undergoes a lumbar puncture, which shows 5 oligoclonal bands that are unique to the CSF, and she's treated with 3 days of IV methylprednisolone, followed by a prednisone taper with complete resolution of the diplopia, and she goes back to normal. This next slide shows her MRI, which on the left you can see the enhancing brainstem lesion on the post-contrast T1 image. The right image is a FLAIR sequence showing a number of typical MS lesions, which are these ovoid hyperintensities in the periventricular white matter. So one key question is whether or not this patient has multiple sclerosis. And the correct answer is that yes, she does in fact have MS. And this would be based on the 2010 revisions of the McDonald criteria. This patient has had one attack with objective clinical evidence of one lesion. So in order to meet the criteria for dissemination in space, she has to have lesions in 2 of the 4 characteristic regions for demyelinating lesions. And in this case, she has a juxtacortical lesion, periventricular lesions, and a brainstem lesion. So she definitely meets that criteria. And then in terms of dissemination in time, she has simultaneous presence of an asymptomatic gadolinium-enhancing lesion, which in this case, the asymptomatic lesion would be the juxtacortical lesion, as well as non-enhancing lesions. So she also has dissemination in time, and we can conclude that she does meet criteria for MS. And our next question is, should the patient be started on disease-modifying therapy? With the options of yes, no, or it's debatable. And in this situation, I would argue that yes, she should be treated with disease-modifying therapy. So let's go through the rationale for treatment in this case and most MS cases. Most patients with MS will become irreversibly disabled if they're left untreated. Neurons, axons, and myelin are irreversibly damaged at sites of CNS inflammation, and this begins from the very beginning of the disease. And secondary progressive MS is a relatively late stage of the disease, but it's probably a consequence of this earlier inflammatory brain injury. So the thought is that if we effectively suppress the inflammatory disease activity in early MS, it's likely to help prevent or delay the onset of progressive MS, which we have much fewer options for in terms of treatment. So the next question would be, what treatment options are reasonable in her case? And the options I've given include interferon beta, gluteramine acetate, teriflunomide, fingolimod, dimethyl fumarate, or all of the above, meaning any one of these agents. And the answer that I chose is all of the above. And to kind of understand the logic behind that, let's go through some of the pros and cons of the listed options, starting with the injectables, which would be interferon beta or gluteramine acetate. The pros of these medications is that they have long-term safety data. We know that they're very safe. They're quite a bit cheaper than a lot of the newer medications, especially the oral drugs, which the insurance companies prefer, and sometimes that can reduce the amount of startup hassle associated with the medications and often allows us to get the patient onto treatment sooner than with medications that require a number of prior authorizations. And these medicines also have a minimal monitoring burden. So as we talked about with interferon, you need to follow the CBC and hepatic function panel intermittently and check for neutralizing antibodies. Glatiramer acetate doesn't require any blood work monitoring. So overall, this is fairly minimal in terms of what you have to check in these patients. The cons associated with these medications includes the fact that they are injections, which patients typically prefer to avoid, although it should be noted that glatiramer acetate is now available in a 3 times per week formulation, and a version of Avonex, a pegylated version called Plegridy, is likely to be approved soon, which will require twice-monthly injections instead of the typical once-a-week injection. The side effects that we have discussed before include flu-like symptoms, the skin reactions with Copaxone, and this risk of immediate post-injection reaction with Copaxone. And finally, interferon beta is thought to possibly worsen some symptoms that are common among MS patients, including spasticity and depression. The data in terms of depression and interferon is somewhat conflicting, but I think that many clinicians do tend to avoid interferon beta among patients who are depressed out of concern that it may worsen their depression. Okay, so the next agent that we had listed was fingolimod, which has the pro that it's an oral agent, so patients much prefer that. It's only once a day, and it's typically pretty well tolerated in terms of side effects. But there are some definite cons to the medication, including the startup hassle, which, as we talked about, you need to get ECG before and after the initial dose. They have to be monitored for 6 hours. They need those 2 OCT exams at least, plus the blood work. So that can often delay getting the patient onto the medication. And then, as we talked about, there are these other risks, including hepatotoxicity, leukopenia, AV block, and risks associated with herpes virus infections. Teriflunomide also has the pro that it is an oral agent, and it's typically pretty well tolerated aside from those occasional GI side effects. But it does require a fair amount of monitoring, as we talked about, the once-a-month hepatic function panels for the first 6 months. Another big concern is that teriflunomide is pregnancy category X, which, given that many of our MS patients are women of childbearing age, that is definitely very concerning. So anybody starting teriflunomide needs to be using strict contraception, and that actually applies to men as well, because teriflunomide can be transferred in the semen and then could potentially harm the fetus. And if a patient does become pregnant on teriflunomide, they need to go through a washout procedure to help accelerate clearance of the drug. And then finally, the side effects that are associated with teriflunomide, as we discussed earlier, GI upset, some hair loss, and an increased incidence of nasopharyngitis among the patients taking the medication. And finally, dimethyl fumarate. Again, the pro that it's an oral agent. It has a fairly easy startup process. Really, all you need is a CBC, although, again, you do sometimes run into payer restrictions because it's one of the more costly medications. Based on the trials, it does appear relatively safe, but there is this risk of leukopenia, and the side effects, most prominently the GI upset that we talked about and the flushing that we talked about. And then, as I mentioned before, there were these cases of PML reported in the different formulation that was used in Germany to treat psoriasis. So how do we choose an appropriate agent among these options that I've listed? Well, my opinion is that it's important to choose an agent that the patient can comply with, because patients who don't take their medication are not going to get good benefit from it. So you need to have a careful discussion with the patient regarding the mode of administration, whether it's injectable, an IV infusion, or an oral medication. You need to discuss the adverse event and risk profile with the patient and kind of assess their risk tolerance to help determine what medication they would feel comfortable taking. And you have to discuss the side effect profile and whether or not the patient thinks they're going to be able to deal with the medication in question. And the idea behind this dialogue is that you can find the medication that the patient is most likely to be compliant with, and thereby help them the most by preventing any advancement of their MS. So let's move on to a second case study. In this situation, we have a 34-year-old man who presents with complaints of left arm and leg weakness as well as slurred speech. 1 month earlier, he had experienced a painful loss of vision in the left eye. He was seen by an optometrist who referred him to neuro-ophthalmology, but by the time that appointment came around, his eye was starting to feel better, so he ended up canceling the appointment. However, as time went by, the eye never got completely back to normal. And the patient also notes that 6 months earlier, he had experienced a band-like sensation around his thorax that had lasted for 6 weeks. But at that time, he had just started an antidepressant, and he thought this was a side effect from that medication. On physical examination, the patient has a left afferent pupillary defect and a left hemiparesis affecting his face, arm, and leg, as well as a gait disturbance. MRI is performed, which shows a moderate to severe burden of T2 hyperintensities, some of which have corresponding T1 hypointensities, and several enhancing lesions. So IV corticosteroids are ordered, and he's treated with a 5-day course, and he gets about 50% improvement of his left-sided weakness. Lab tests are also conducted and show that he has a normal hepatic function panel, a normal CBC. He's negative for JC virus antibodies, and he does have a positive VZV IgG titer. And this next slide shows his MRIs, which you can see that he does have a fairly significant lesion burden over on the left. And on the right, you can see that his brainstem is affected, and you can also see that he's got some early atrophy as the sylvian fissure is becoming fairly prominent. And on these post-contrast images, we can see that he does have at least a couple enhancing lesions in his brain. And on the next slide, you can see he also has some enhancement in his cervical spinal cord. So the question at this time is, what's the best treatment option for this patient? And the options that I've listed include interferon beta, glatiramer acetate, natalizumab, fingolimod, dimethylfumarate, and teriflunomide. Well, in this situation, I would argue that natalizumab is the best choice. So you might ask, why natalizumab? And the answer is that this patient has several indications of an aggressive disease course. This includes the fact that he's had multiple relapses in his first 2 years, in fact, over just the last 6 months. He has early atrophy on his brain MRI, which is a predictor of later disability in MS. And he's had poor recovery from his relapses. His vision never went back to normal. His left-sided weakness has not gone back to normal, even with steroid treatment. He has a high burden of lesions on MRI, and he had multiple enhancing lesions. Natalizumab is an effective treatment, highly effective, in fact, both in reducing relapses and new lesion formation. And this patient is at low risk for the main adverse event that people experience with natalizumab, which is PML, and that's based on the fact that he is negative for the JC virus antibodies. So in this case, in which we have a patient who has an aggressive disease course, we need to be aggressive in terms of our treatment of him, and natalizumab would be the best option to control his disease. This next slide just summarizes our ability to stratify a patient's risk for PML when they're treated with natalizumab. And three main risk factors have been identified. These include the length of treatment with natalizumab, more or less than 2 years, any history of immunosuppression, and their JCV antibody status. So in this patient's case, he's JCV antibody negative. He has not received prior immunosuppression, which would be with medications like Imuran or Cellcept or Cytoxan, none of which he's received. And he has been on treatment for less than 24 months. So his risk of PML for those first 2 years would be about 1 in 45,000, so very low. His risk of PML after 2 years would still remain very low at about 1 in 5,000. So natalizumab is a reasonable first-line option for patients who appear to have aggressive MS. And I think there are some MS experts out there who would argue that natalizumab is a reasonable first-line agent even in patients who don't have aggressive MS, but who are JCV negative and therefore at very low risk for PML. As I mentioned, it's especially appealing if the patient has not been exposed to JCV antibodies. Natalizumab can be used with relatively low risk for up to 2 years, even in patients who are JCV antibody positive. But most patients after 2 years will elect to switch to an alternative treatment. And you need to keep in mind, if you employ that strategy, that such patients might be at risk for significant rebound disease when the natalizumab is stopped. And one way to help try to prevent that is to try to get them onto a different disease-modifying therapy as soon as possible after you stop natalizumab. Our final case study today is a 24-year-old woman who is hospitalized with optic neuritis in her right eye, and she's treated with steroids and makes a full recovery of her right eye visual acuity. She has a lumbar puncture, which shows a mildly elevated IgG index, but no oligoclonal bands. And she follows up 3 weeks later, and on examination, the only abnormality is that she has a right relative afferent pupillary defect. She denies any episodes of neurologic impairment in the past that would be suggestive of an MS relapse. And this is her MRI. On the left, you can see her FLAIR sequence is very mildly affected with one clear periventricular lesion and maybe a couple punctate subcortical hyperintensities. And her cervical spine is completely negative over on the right. So this patient has a clinically isolated syndrome. And we need to ask ourselves, should she be started on disease-modifying therapy? And our answers, again, are yes, no, or it's debatable. And in this case, I would say that it's debatable. I'm sure there are MS clinicians out there who would start this patient on treatment, and I would certainly not fault them for that. But there are a number of features in this patient's case that suggest a mild course. This includes the fact that she has a very mild lesion burden on her MRI. She's made a full recovery from her initial relapse. Her spinal fluid did not show any oligoclonal bands, which reduces the likelihood of a second attack, and there was no atrophy on her MRI. And there are some definite advantages to monitoring a patient off of therapy. These include the fact that disease-modifying therapies are associated with side effects and adverse events that would be preferable to avoid if possible. Disease-modifying therapies are expensive. Sometimes significant costs can be incurred by the patient, and sometimes they can be uncomfortable for the patient, particularly in the case of the injectable medications. So if you decide to monitor this patient off of therapy, it is important to keep a close eye on her. And the strategy that I typically employ would include fairly frequent office evaluations for any signs of disease activity, such as a relapse or worsening on her examination, and MRIs to monitor for subclinical radiologic worsening. We do know that a great deal of active disease can occur beneath the surface that does not necessarily produce symptoms in in the patient, and that's why I recommend the serial MRIs. And my usual scheme is an MRI about 6 months after that first event, and then 6 months after that MRI. And if those two MRIs are stable, then I'll typically go to repeating the MRI about once a year, with the understanding that if new disease activity becomes apparent on the MRI, then the decision to monitor off treatment needs to be reconsidered. It would not be unreasonable to space out the imaging a little bit more depending on the clinical situation and at the treating neurologist's discretion. And finally, monitoring on therapy, I actually use basically the same scheme of checking the patient frequently for relapses and following their MRI. And the idea here is that if a patient is demonstrating any new lesions or is having relapses, that's suggestive of breakthrough disease despite treatment, and the neurologist would really need to consider alternative treatment options at that point. And finally, to go through a few conclusions from this talk, most patients with MS will become disabled without treatment. All of the MS treatments can be considered in different situations, but multiple factors need to be taken into account. These include the disease severity, the patient's risk tolerance, the side effect profile of the medication and whether or not the patient thinks they can handle the involved side effects, and restrictions that the payer may put on what medications the patient can take because of the cost of the medications. If a patient has aggressive MS at presentation, aggressive treatment should be considered. In particular, Natalizumab should be considered, especially if the patient is JC virus negative and has no history of immunosuppression. Once therapy has been started, monitoring is necessary to check for any disease worsening, such as would be evident from a relapse or MRI activity. And a similar approach can be taken to monitor a patient off therapy so that you can reassure yourself and the patient that there's no disease activity that suggests they need to get onto a disease-modifying therapy. Okay, thank you very much.
Thanks, Dr. Conway, for your helpful talk on initial management of MS. In this time when medications and medicine are becoming more and more complex, it's important to step back and think in larger terms about groups of medicines for patients. The decisions sometimes come down to a series of questions for the patient and clinician. Do they want to use injections or pills? Do they like tried-and-true medicines with a long-term clinical track record, or do they want the latest thing? How averse are they to risk of medicines? What's the MS been like, and how aggressive does treatment need to be? Medication choices used to be simple, and now are complex. Dr. Conway's talk helps us to sort out how we might help our patients make these choices in a rational, meaningful, and cooperative fashion. Please remember to fill out your forms for CME credit, and thank you for attending this conference.